ताकि YouTube वालों को फायदा हो जाए. Okay, so today's presentation, which was requested by one of the trainees, and he wanted to know the terminologies like fugue, like amnesia, and those kind of things, what actually are there in dissociative and conversion disorders terms used. So I will be explaining most of these terms associated with or around conversion. So there are a few things which unfortunately are not in conversion disorders, but sometimes it's very difficult clinically to see whether this is a conversion disorder or it is something else. So that was the main part of it. If somebody complains to you about fugue or anything, then how you would be able to assess it. So that was the main target of this presentation. And I will try to explain all these terms which could be related to this subject. Okay. So terms used in dissociative and conversion disorder. When I was doing my training in early 90s, from 91 to 95, my professor used to quote a lot about us. One of the study which was published in a neurology journal, it was done in probably 60s or 70s, a study by Slater, where he found that most of the people who are having dissociative or conversion disorders, most of them were having some neurological findings in their examination or in other testings they were doing at that time. And it was a very significant study. So he concluded that most of the patients who are having dissociative disorders are actually having some neurological disorder. And then when I did my FCPS and started seeing the patients, I had lots of, again, arguments with lots of people around, and I was trying to convince them that dissociative and conversion disorders, they do have organic basis, and we have to be careful about it. And when we are trying to assess them, so that we are sure that we should be trying to assess the neurological component in these patients, although they are presenting with very typical symptoms of conversion or dissociative, still we should be trying to evaluate them neurologically. And most of the people, they never agreed to me, and they said, well, no, dissociative and conversion disorders are like this. Now, there are multiple studies over the past 3 to 4 years' time, which are showing that there is definitive some neurobiological component in all of these patients, either at neurotransmitter level or some circuitry or some other component where they are evident. If we see various dissociative disorders, amnesia is only 6%, fugue is 17%, well, 21 to 20, there is total number of 80 people. So out of them, 21% were having fugue state. I personally have seen fugue much less than what is mentioned here. But of course, fugue could be one of the major symptoms. When I will be talking about the fugue, I will explain it to you why I said that it is much less common. Stupor, yes, in this study, they never saw any person with dissociative or conversion stupor, but I have seen few of them. So it varies from clinical to clinical experience, cultural background, social components, and various countries across the globe. Once and depression syndrome, in this study, they quoted 30%. And I believe that probably it is more than that as well. Motor disorder, convulsions, anesthesia, and other mixed dissociative. So this is breakdown from one of the studies out of many. When we say dissociative amnesia, now this amnesia could be localized, selective, or generalized. Localized, like they will try to forget about a specific period of time. specific event. Like even today, when I was seeing one patient in a clinic, he actually did something when the university people were, he was a young boy, did something that he switched off the light and ran towards a window. And earlier he communicated to his friends that he will commit suicide. So all the students ran after him and stopped him, and they thought that probably he's going to commit suicide. And today, when I was talking to him, this was about months ago, he said, I don't recall any of that event, and I never intended to commit suicide. I was just probably joking around with my friends. So things do change, and when I wanted to know the specific detail of that event, he was not able to recall it. So this is localized amnesia. Then selective amnesia. So some of the information they are able to recall, and some of the information which probably they feel is more traumatic to them, they don't want to recall it. Like month of the years when I was 5 years old, I was probably again faced some sexual abuse, molesting, or something like that, and they usually forget. So this happens to normal individuals as well, and this happens more commonly during our period. We try to again suppress or repress the feelings and emotions which are bad in us, and try to pronounce and project more of the good events, which is again a defense mechanism. And I believe it's a very good defense mechanism which we keep us sane and alive and healthy, and keep on interacting at this point in time rather than living in the past. Generalized amnesia, when you forget everything. So one's life history, I don't know where I am, why I'm doing, what is my name, blah, blah, blah. So these are the three types of amnesia usually seen in a dissociative disorder: localized, selective, and generalized. Then what is dissociative amnesia? It is when a person experiences a significant loss of memory surrounding important personal information. These symptoms of amnesia do not include simple forgetfulness, like not knowing the date. These episodes can begin suddenly and generally last for a short period of time, but have also been seen to last for weeks and possibly even years. So the time duration is variable. Some of the people who presents to us in the emergency or in the wards and outpatient department, they do have these symptoms. They last for a few hours, and then the people are okay. Sometimes they last for weeks, and those are the people who are coming actually to see us in outpatient clinics. For years, if it is lasting for years, of course, it's complicated, it's chronic, it's more of the thing which is evident to everyone. There is another phenomena with the dissociation, which is depersonalization and derealization. Now, both of these phenomena are as if phenomena. That's what we call them, as if phenomena. I feel like my thumb is made of wax. I feel like I am experiencing numbness in my whole body. Although it's not numb, but I feel like it. So depersonalization is the perceptual alterations. This is space, I cannot feel the distance, again, the time, unreal, unstable, absent self, emotionally, physically numb. They say, again, you are quiet and just numb and not talking about anything. Most of the time, these phenomena occur to the normal individuals as well. And again, it is one of the common coping mechanism to cope up with the stress which is happening around us. So that is depersonalization, and derealization, as if it is not there, not existing, or foggy, or not again able to feel it. Like as I gave you example, like my thumb is made of a wax, so I cannot feel it. Lifeless or static, blurry. That is derealization. Now, both these phenomena, they don't have actually a diagnostic significance, because as if phenomena happens to normal, healthy individuals as well. So where we have to draw the line that this derealization or depersonalization is dissociative and this needs some intervention, or this is just, again, a normal phenomena and it will be over very soon. So that is tricky, but this usually depends on the whole of the dissociative diagnostic criteria. Another phenomena is identity disorder, disruption of identity characterized by two or more distinct personality states. So identity disorder means the whole of my identity changes. At this point in time, I'm talking to you as Dr. Nasar Khan, but maybe just after 10 minutes, I will be maybe Zaman Khan. And Zaman Khan will behave differently, will act differently, will talk differently. And it occurs in gaps. It is never a lifelong thing. And then you are not able to recall why I changed that thing, why my personality changed to another one. Symptoms cause clinical significant impairment in social and occupational functioning. Disturbance is not accepted for cultural and religious practice, and symptoms are not attributed to effects of substance or other medical condition. I haven't seen this too much, so I won't be able to give you the precise details about it. Dissociative identity disorder usually is, again, in literature, it says it is there, but in clinical practice back in Pakistan, it's seen less, relatively less. Some of the symptoms of the presentation, which are distinguishing symptoms, are again like conversion people present as of they are blind, or they are deaf, or they have epileptic like seizures, or they have trembling, tremors, or they have paralysis of their anesthesia. I won't go into this detail because these are commonly seen and you all are probably aware of it. Patients presenting in the emergency or in outpatient clinics, they come with the blindness or they have convulsions or some kind of a tremors, which is unfortunately complicating, and you try to examine, try to assess, and you come to the conclusion that this is probably conversion disorder. Conversion disorder, which is now called a functional neurological symptom disorder. This name itself is quoting that there is neurological. Both ICD-10, ICD-11, and DSM-5 now more related to the biological conception of all the diseases. And functional neurological symptom disorder, now there are so many papers available which says that there is definitely neurological symptoms, but there is some background neurological abnormality as well. A somatic psychiatric disorders involves neurological type symptoms affecting movements or sensation that cannot be explained by a neurological disorder like non-epileptic seizure or limb paralysis. Rare, more common in females, involuntary, not an issue of malingering. So we all know that, so I will move forward. Now, functional neurological symptom disorder, it has to be an acute episode, persistent, specifier, which you use a primary gains and the secondary gains with psychosocial stressors, without psychological stressors, and prevalence is about 5%. Well, again, it depends from place to place. It presents with multiple things, the mixed dissociative, amnesia, fugue, stupor, trance, possession, motor, anesthesia, or sensory loss. Now, what is fugue? Psychogenic fugue is a sudden, unexpected travel away from home or workplace. So I will start my car, I will start driving, and I will be driving for hours, and then suddenly I will stop and I realize that I'm at a place which is different and I don't know this place. The whole of the journey from my house to somewhere new, Locality where I was driving is absolutely unknown to me and unknown about the passage of time as well. These people sometimes, again, back in our country, these people usually like travel from Lahore to I had no recollection of how I went to the station. I picked up a train, I sat on it, I went to Peshawar, and then after 3, 4 days, I realized that I am in a different place. And then there was some recollection, and I came back. Now, I have seen this, but usually, again, it's very rare. The onset is sudden, often in presence of severe stress. Following recovery, there is no recollection of the events that took place during that few time. So how I went there, what I did for 3 days, where I was sleeping, how I was eating, blah, blah, everything is absolutely vague. And most of these patients, when they present to psychiatrists, they are usually brought by the family that he disappeared for 2, 3 days. And now he says that I don't know where he was. Mostly in the background, there is some stress and complications. And when you take the history, you are able to understand. It is a dissociative disorder with a sudden loss of memory and assumption of a new identity in a new locality, right? Ganser syndrome. Now, this is another important thing. Ganser syndrome. A characteristic feature is Warburden, German word, I cannot pronounce it properly, giving approximate answers to the question. Ganser syndrome is actually dissociative or conversion symptom, and they are always approximate answer. Approximate answer means if I'll ask how many legs a cow has, he will say 5. Okay, how many fingers do you have? He will say 7. Uh, how is the weather today? Is it warm, hot? And he will say, no, it's very cold and it's winters. So he will give the answers in the relevant domain, but the answers are above or below. When asked to add 3 and 3, a patient might answer 7. When you ask about the 4 or 5, might answer 10. Each answer is one greater than the correct answer. Hallucinations are usually visual and may be elaborate as well. So they will give a description of hallucination as well, that I'm seeing objects, I'm perceiving something happening, and they will give approximate answer. Now, Ganser syndrome has its own background. Most of the time, it is to gain something. So a variation from malingering to a Ganser syndrome into a dissociative is usually the task most of the time, which is difficult to understand. Trance disorder. Now, the trance, which usually is in our culture, it is said to be hal pad gaya. Hal pad gaya ya daura pad gaya. So people in this is very common in our culture, the trance state. If you go to our, again, lots of mazars around us where a loud music is played and people are dancing, or usually during the Qawwali night, people do have a trance state when they disappear from the existing place and they are into some other domain. So they feel that they are possessed and they are disconnected, और उनको हाल पड़ गया और वो गायब हो गए और वो किसी और जगह पे पहुंच गए. Another word used for the trance state in our society is again dhamal and hal and murakba. कि जी वो मुराकबे में चले गए. Now murakba is something, again, a different state of mind, but usually these things are overlapping. Feeling disconnected from ourselves and the surroundings, and you start doing something even though it's not acceptable. People feel that, oh, he is in a state of mind which murakabe mein chale gaye, and it's something supernatural, super powered, out of the blue, in spiritualism, etc. And they lost the connection with the immediate surrounding. They speak different dialects, vocal tones, behaving as if they are somebody else. autobiographically different. Visual and auditory hallucinations are there as well. So they start seeing something. Now, these things are present in sometimes in substance abuse as well. So we have to make sure that there is no history of substance abuse before we declare that this is a dissociative or conversion trance disorder. So that is important component. Another phenomena which for a long time I also believe that is an epileptic phenomena, temporal lobe epilepsy, is automatism. Automatism is general principle of volition. It can arise as a defense with automatism. D acts involuntary, concussed under administration of anesthesia, psychological trauma, or blackout. And it can be complete destruction of voluntary control. Automatic movements. So automatic movements like uh, he starts shrugging the shoulders and disappears for a while, or he starts moving his arms and disappear for a while. These automatic phenomena or automatism is seen in temporal lobe epilepsy as well. In most of the old neurological books, it is a type of an epileptic phenomena. But some of the literature now is coming up which says that it is not an actually epileptic phenomena. It's actually a dissociative or conversion phenomena, more psychological than neurological. So there is still some complications around it, but it is definitely seen in people with stroke, pneumonia, and sleepwalking. And it is not now considered an epileptic seizure. It is psychological effects of being rejected by a girlfriend or boyfriend, etc. So they feel that it's some kind of a neurological issue, and it's not epileptic, but it is neurological, like chewing movements or smacking movements or hand wringing movements, or you start moving your legs automatically for short period of time, and then you are okay and you have no recollection of what actually happened to you. Still, automatic phenomena, considering temporal lobe epilepsy, is treated as an epileptic phenomena and anticonvulsants are prescribed for it. We still need to have more details of it before we declare it psychological than automatic. So there is hypermotor phenomena. There are four clusters: vocalization, elementary motor, version, automatic sign, and emotional component to it as well. Insane automatism. So previously, people will find that this was an epileptic phenomena. So I got up, I pick up the pistol, I went to somebody's house and killed them. And in past, people were actually declared unfit and not guilty by reason of insanity, a special verdict in past. But now they say no, it is not possible that you can do some very precise act during your automatic phenomena, like picking up a pistol, going to somebody's house, pulling the gun on them and shooting them. This is not possible in automatism. It is so now it is not considered to be again a possibility that he will be not guilty by the reason of insanity. But insane automatism is definitely they take up the advantage of that they were epileptic or hyperglycemic, or they were having cerebral tumors, multiple sclerosis, sleepwalking, arteriosclerosis, or hypoglycemia, which can lead to these automatic phenomena and then not guilty by the reason of insanity. So there is a debate still going on. Is it really like that? The person can commit a crime during that automatic phenomena. They lost everything, sense of reality, and do this thing. So it's not practically proven. And most of the neurological books, they say they know it's not possible to do that. Non-insane automatism occurs in head injury, anesthesia, sneezing, and PTSD. And usually, again, they are not again uh, disposed of because they were suffering from something and injured somebody. So they are having a trials. An act done by the muscles without any control by the mind, such as a spasm, a reflex, action, or a convulsion, or an act done by a person who is not conscious of what he's doing, such as an act done with less suffering from concussion or sleepwalking. For jury, again, legally, now it contains no. Now, trance and possession disorders are one of the main symptoms in dissociative disorders as well. How much they are considered to be normal in our culture? Very much. How much they are actually abnormal? Very much. So, in trance and possession disorders, as I mentioned earlier as well, this condition is characterized by temporary loss of identity, an acute narrowing or complete loss of awareness of the surrounding, presence of profound unresponsiveness or insensitivity to environmental stimuli, minor stereotyped behaviors, finger movements, of which the individual is unaware that he or she cannot control. Now, this is muraqabah. When you sit, try to focus yourself to some supernatural thing and supernatural powers come to you and you lose sense of control around you. That is muraqabah or a trance state or a possession disorder. But a new term recently introduced is hypnosis and hypnotics. Not hypnotics, the medical drugs. Hypnotics, the people who have the capability of hypnotizing people around them, and they can actually make whole of the public hypnotized, and then they can make them do whatever they want to. This phenomena gained lots of power in 80s actually, when there were some people, I don't want to call them again, and they started using these spiritual powers, and there was a mass suicide. About 80 people committed suicide because of one leader who actually hypnotized them and made them do that crime. So that was the hypnotic person, and he actually made sure that everybody was in a state of mind where they all ended up their life. Now, there is again still lots of research needs to be done about it. How this hypnosis or hypnotic people were able to control so many people, and how they moved them to do some act. There is a new movie as well, Hypnotics, in which the same kind of a thing is applied. It's again very popular, again cast related to it, and they were doing the mass hypnosis and making sure that then you start feeling that these things around me, they are not this. I am walking in a New York. Although I'm sitting at home, I feel like I'm walking in New York, maybe in some different street, and I can do whatever I feel like doing. So this is now gaining more power after that 80s incident. And then there were certain other things happened as well in the similar context. So people started realizing why this is happening in the groups and or masses, and why one person leading the other people into some kind of a thing. That is something new. Hypnotherapy, we all know that hypnotherapy is a kind of a therapy which schizophrenia are more prone to these suggestions under hypnosis. Right, yes. So there are so many ifs and buts associated with it. And we know hypnosis, that hypnosis is a kind of a therapy which was initiated in 18th century when they were using some material in their hands, moving it in a very good motion, and then people were just suddenly disappearing from this state of mind. Hypnotherapy is used to actually recollect the past memories and to again disintegrate the traumatic memories from the past and make sure the person gets well. There are again various ifs and buts to it, how much it is successful, how much it can help people. People use hypnotherapy for smoking cessation, people use hypnotherapy for pain, hypnosis for, again, getting relaxed, getting rid of the traumatic memories, blah, blah, blah. So how much it is effective? Because there is no concrete evidence-based studies with the hypnotherapy, so I cannot say that. But just imagine there are more than 3,000 registered hypnotherapists in UK. 3,000. Now these are 3,000 in UK only. You can imagine how many hypnotherapists will be available in other parts of the world, where it is practiced a lot. So it is one of the way of, again, making money or doing something like that. I don't know for sure if it works or not. And people say that the conscious mind and the subconscious mind, and there is a critical mind. So analysis, thinks, and plans and short-term memory is, again, conscious mind, which is 12%. Long-term memory, emotions, feelings, habits, relationship, involuntary body functions, creativity, developmental stage, and intuition, they are all subconscious mind, which we know from Freud theory, but how much it plays role clinically in day-to-day life, I have doubts about it. Hypnosis is a state of human consciousness involving focused attention and reduced peripheral awareness and increased suggestibility. Fixed gaze induction, rapid command using firm rapid commands, progressive relaxation, loss of balance, all of these things, they are there in hypnotherapy. So if you want to go through that, it's a whole range available. There are books and books on hypnotherapy and suggestibility and how to improve your body-mind connection, etc. Now, some other terms, more terms that needs to be elaborated with the conversion. Of course, they are not conversion, but with conversion, like transient tic disorder. So these are single or multiple motor or vocal tics that occur many times a day, nearly every day for more than 4 months, but no longer than 12 consecutive months in children. These are transient tic disorder. Now there is a tic disorder as well, right? Vocal tics and motor tics. Vocal tics, uttering obscenity, goes into Tourette syndrome. And then we have to differentiate it from Tourette's or some other syndrome. Tourette syndrome actually can happen in adults as well, right? So it's not, previously it was thought that it is just happening in the children, but it can happen in adults as well. Then there are chronic motor or phonic tic disorder. Single or multiple motor or vocal tics. Now, these tics appear frequently on most days for more than a year. So the tics keeps on appearing, like this could be a tic, or maybe. Now, how you will differentiate the tic from automatism clinically is more of an elaborate history taking and evaluation of the person. Automatism, as I mentioned, occurs infrequently, right? And may be related to partial or maybe unconsciousness when person is absolutely not sure of it. In tic disorder, the consciousness is absolutely intact. They know where they are, they're cautious, they know that this thing is happening to them, a vocal tic is happening to them or a motor tic is happening to them, and they understand it as well, but they are not able to control it. So both vocal and motor tics, if they are combined together at the same time, like swearing, right? One of my patients uses F word at least 17 times in just one conversation. So I ask him a question, how are you? And he will use 5 to 10 times F word in his conversation. This could be, again, a tic disorder or a Tourette syndrome. So that is what needs to be understood clinically as well. So we need more details, history, diagnostic classification system for tic disorder, and understand automatism and understand conversion before reaching to a conclusion. And that was one of the reasons why I included it here. Mannerism is a habitual characteristic manner, mode or way of doing something, distinctive quality or style as in behavior of speech. The way you talk, gesture, example for mannerism. Like I have a mannerism that when I talk, I move my hands very frequently. So to express myself, to reinforce what I'm saying, I move my hands. And this is mannerism. And this is normal as well, but it could be problematic if it is happening in a way which could be probably getting a space from others as well. So if I'm crossing my boundaries with these mannerisms, it could be a problem as well. Like I correct my hair like this at least once every minute, it could be a mannerism, non-goal directed movement. But if it starts disturbing other people and it starts disturbing my work, then these mannerisms are complicated and we have to make sure that we have to treat them. Mannerism could be standing up straight, making an eye contact while talking, smile as it conveys happiness, poor preparation, anxiety, language problem, etc. So there are positive mannerisms and negative mannerisms. And when negative and mannerism includes the, again, this nail biting as well. It could be one of them, but needs treatment if it is there. And lastly, but not least, stereotypies, verbal stereotypies or motor stereotypies. Now, stereotypies are oversimplified perceptions of people based on their characteristics. They can be harmful because they involve making premeditated judgment about others. Common types of stereotypies include gender, race, sexual, social class, ability, age, nationality, political, religious stereotypies. If I have a belief system that all men are aggressive, this could be an actually stereotyping. My fixated belief about men that all men are aggressive people. Now, it could be rational or it could be irrational, but if it is crossing some boundaries, then it could be basically a big problem. So we have to understand what we are talking about and where we have to put a full stop during our conversation. If somebody is not able to put a full stop to the conversation, which could be, again, sexually related, they are able to talk about it publicly as well, then of course it could be a problem and it needs intervention and treatment. So the stereotypies are also one of the problematic things around there. Okay, so this is what I wanted to present. Any questions related to it? Anybody, if they want to ask a question? No? सब समझ आ गया या कुछ समझ नहीं आया?
सर मैंने बस ये अच्छा सर मैंने ये कहा कि ये हम लोग जो क्लिनिकली इतना कम ये चीजें देखते हैं कि इनको क्लिनिकली कोरिलेट करना काफी मुश्किल लग रहा है.
अच्छा, अब इसमें अवैस में एक छोटी सी बात बताऊं. वो कहते हैं कि eyes cannot see what the mind don't know, right? So this is a very common phrase. अगर आपको ये टर्म्स का पता हो तो आपको ये बड़ी कॉमनली नजर आएंगी, राइट? और जब आपको इन टर्म्स की डिटेल्स का नहीं पता होता तो फिर आप फोकस नहीं करते. सो मेरे पास जब पेशेंट एंटर हो रहा होता है ना कमरे में, सो मैं उसको देख रहा था वो कैसे चल रहा है, वो कैसे आगे आया, वो कैसे कुर्सी पे बैठा, उसने कैसे हाथ आगे बढ़ाया, कैसे मुंह के जेस्चर्स दिए. That observation is very important. These are common things like mannerisms, stereotypies, automatism, sometimes again other states. अब trans state भी जो है, this is again very common. You go to any mosque in Pakistan where after the prayers there is a gathering to listen to some specific talk or something, you will find that people go into the trance state even there, especially people of my age or middle age. They do they. When you know these things, these phenomena, you'll be able to see them commonly happening around you. When you don't know them, you don't see them. So these are actually common presentations in outpatient department as well, depending upon how you see or assess them. Right? कोशिश करो अब थोड़ा सा देखो अपने इर्द गिर्द 2-4 दिन ओपीडी में कि कितने पेशेंट्स को मैनरिज्म हैं, स्टीरियोटाइपीज हैं, टिक्स हैं, अगेन और दूसरे फिनोमेनास हो रहे हैं, और तमाम डिसोसिएटिव पेशेंट्स को you start assessing them for the neurological symptoms as well and see how they come up with it. You will be surprised with the findings that you yourself will be start seeing. Right? देखो फिर we can discuss about it. Anybody else?
सर मैं ये कहना चाह रहा था टिक्स और टार्डिव डिस्काइनेसिया दोनों के हवाले से कि इसमें थोड़ा सा मामूली सा शायद वॉलंटरी कंट्रोल होता है एंड दे कैन डिफर और पोस्टपोन इट फॉर सम टाइम, लेकिन वो बहुत ही मुख्तसर अरसे के लिए उसको कंट्रोल कर सकते हैं. उसके बाद वो जितनी देर के लिए वो उसको कंट्रोल करते हैं उतना ही फिर उनको टिक्स ज्यादा करनी पड़ती हैं, ज्यादा डिस्चार्ज करनी पड़ती है, ओवरऑल डिस्चार्ज उनकी उतनी ही होती हैं. That's what I...
Absolutely. टार्डिव डिस्काइनेसिया में लोग समझते हैं कि जी वो रोक नहीं सकता. वो रोक सकता है थोड़ी देर के लिए और बड़ी एफर्ट पुट करके, as Kamran mentioned. Yes, even tardive dyskinesia, people have some voluntary control over it for a shorter period of time, but then it starts reappears and it reappears with more force, more energy, and more aggressive. Same goes for the other things as well. So the mannerisms, the stereotypes, the tics, people are able to control themselves. In tic disorder, definitely person understand that this is a problem with me and I have to control in public. They try to, but most of the time they are successful, but that afterwards it's a big problem for them and they feel very distressed afterwards as well, which is again a problem, right? Okay, so I hope that this presentation was able to give you some insights about various terminologies around this area. I may have missed some of them, but I tried to gather as much as possible. With some of the differential diagnosis previously, I talked about the dissociative and conversion disorders. If you combine these there, I hope it will be better for you, right? Any other question? No? Okay.
मेरा एग्जाम पॉइंट ऑफ व्यू से थोड़ा सा था क्वेश्चन कि
बोलो.
उसमें ऐसे पेशेंट्स को कैसे टैकल करना है. उसमें पहले हमें जैसा डिप्रेशन और एंजाइटी इन चीजों को रूल आउट करने के बाद हमें डिसोसिएटिव पे जाना है. आई थिंक इसका लेकिन लेक्चर से ताल्लुक थोड़ा कम है, लेकिन एग्जाम पॉइंट ऑफ व्यू से मेरा क्वेश्चन था.
एग्जाम पॉइंट ऑफ व्यू में अगर आपको किसी पेशेंट में नजर आ जाता है कि दिस इज अ पर्सन हु इज हैविंग सम टिक्स, राइट, सो डेफिनेटली आपने हिस्ट्री तो फिर भी पूरी लेनी है. आपने उसमें सारे डायग्नोसिस को रूल आउट करना है, जनरल मेडिकल कंडीशन को, सब्सटेंस अब्यूज को, मेजर साइकाइट्रिक मोबिलिटी को. और अगर आपको मिल जाए लॉट्स ऑफ पीपल विद टिक डिसऑर्डर ओनली और द टूरेस्ट सिंड्रोम, दे प्रेजेंट्स एज अ साइकोटिक पर्सन, or they present to you with anxiety symptoms, or they present to you with OCD. Now, lots of people with OCD, they do have some of tics and mannerisms as well, and stereotypies as well, because of their OCDs or because of other. So this is a big thing. It can be comorbidly present with other disorders, or it may be seen independently as well. Seeing as a comorbid is a big chance. The comorbidity is common in all of these disorders, even dissociative, conversion disorders. I did a study and I declared that 70% of the people with conversion disorders, they had major depressive disorder symptoms in them. 70% is a very big number. So whenever a dissociative disorder person comes to me and I assess them and I feel that they are having depressive disorder, with the other methodologies that we used, I do prescribe them medication. Now, there is a new study which clearly indicates that in conversion and dissociative disorder, there is some neurohumoral and hormonal and serotonergic pathways disturbances, MRI पे और दूसरे पे. लेकिन आपको एग्जाम सिचुएशन में डेफिनेटली सारी साइकाइट्रिक मोबिलिटी को इन पेशेंट्स में पूछना है, क्योंकि सिंगल आइसोलेटेड टिक डिसऑर्डर शायद एग्जाम में मुश्किल हो, लेकिन कंबाइंड विद कोमॉर्बिड सिचुएशंस दे विल बी देयर. सो यस, असेसमेंट पूरी होगी आपकी एग्जाम में. मेंटल स्टेट एग्जामिनेशन भी आप सारा मेंटल स्टेट करेंगे, उससे हेलुसिनेशंस, डिलूजन सब कुछ पूछेंगे. उसका न्यूरोलॉजिकल एग्जामिनेशन भी आप ब्रीफली जरूर करेंगे. और फिर अगर आपको कुछ नहीं मिलता और सिर्फ टिक्स हैं तो आप मेंशन कर दें. और अगर आपको कोई मेजर साइकाइट्रिक मोबिलिटी मिल जाती है अलोंग विद द टिक्स तो आप मेंशन करें. दैट इज द बेस्ट वे टू मूव फॉरवर्ड, राइट?
जी सर, थैंक यू.
Okay, thank you very much everyone for coming in. And if there'll be any questions or anything, text me in the academics group. Allah Hafiz.